Hi, everyone. My name's Kayla. I'm one of the nurses at Genesis. I'm going to be telling you a bit about what to expect during an IUI or an ovulation induction cycle at Genesis. So to start with, I wanted to go over a bit about what the menstrual cycle phases entail. We first start with the follicular phase. So day one would be when day one of the follicular cycle is when a patient gets their period. So it's the pre-ovulatory portion of a woman's cycle when a follicle begins to grow and the uterine lining starts to proliferate. The follicular phase, often depending on how long a woman's cycle lasts, can be around 10 to 14 days, can be longer, can be shorter. The ovulation phase comes next. And that's when the ovary releases a mature egg, which will then travel down the fallopian tube to get ready to be fertilized. Ovulation comes after about 24 to 36 hours after an LH surge. Luteinizing hormone, the LH surge, is another hormone in our body, and that indicates when ovulation will begin. This whole phase, the ovulation itself, lasts about 24 hours-ish, give or take, and then comes the luteal phase. So it's the post-ovulatory portion of a woman's cycle where the corpus luteum provides progesterone, which causes the uterine lining to thicken up. And that's usually what gives an embryo support to grow in the uterus. This is just a photo that shows the different phases of the menstrual cycle. So there's the follicular phase, and then the ovulation phase where the endometrium thickens, the luteal phase, and then essentially the menstrual phase again, where our bodies cry if we don't get pregnant, unfortunately. But yeah, and then the whole cycle will restart. So there's many reasons infertility can occur. It can occur due to female factors such as, unfortunately, women do have a biological clock, so to speak, where once we pass the age of 30 and especially 35, our ovarian reserve decreases. So the quantity and the quality of our eggs do decrease. There are male factors that can cause infertility as well. For example, if sperm doesn't move correctly, if there's not a lot of sperm there, which is often why sometimes doctors will recommend doing a sperm analysis prior to starting treatment, just so we can see if there are any male factor issues before we start treatment, so we can see if that would be a cause. And unfortunately, there are a lot of unknown factors that can cause infertility as well. We can try our best and do as much testing as we want, but sometimes there's not a clear-cut answer for why someone may not be getting pregnant. With all that being said, though, we do a lot of prerequisite testing, a lot of different diagnostic testing as well in order to get a bigger picture of what a patient's issue might be that's not allowing them to get pregnant. And there are a lot of options that we can begin to assist them on their fertility journey. So at your first visit with the doctor, they'll typically do an initial consultation and just review your general medical history. Oftentimes they'll perform a physical exam. Sometimes that'll also include an ultrasound. Not every patient will do blood work, but some patients will do blood work depending on what day of their cycle they're on, for example, or depending on how the doctor and the patient agree on moving forward. They might do some testing then or recommend a follow-up appointment in which testing will be done. But usually this is a very standard appointment where it's just discussing your medical history, how long you've been maybe trying to get pregnant, and just your goals and what treatments you might be comfortable with and not comfortable with. But it's a very baseline appointment, and you can have all your questions answered and hopefully come up with a plan to start your journey in fertility if that's something you hope to move forward with. Typically, prerequisites for an ovulation induction cycle will include testing such as AMH level. This is just a blood test that gives us an idea of the ovarian reserve, along with day 2 to 3 testing with your FSH level. This is also blood work that's done on day 2 or 3 of a patient's period, and it together gives us an idea of the quality and quantity of eggs based on both of these blood works. We'll also do fertility panels on both the patient and their partner. If it's been like a year, for example, since they've done this generic fertility panel, we'll have them repeated as well. It tests for a normal standard CBC blood work, metabolic panel, and it also will test for infectious diseases, just because we can't start treatment depending on if a patient has not been treated for an infection. Some patients might not know if they have a current infection, so we just have to make sure everything is okay before starting treatment. Another prereq would be genetic screening. So we usually will have a patient and their partner do blood work for genetics as well. And we are looking to see if the patient and their partner have an overlap for the same genetic disorder. If they do, that can cause they might want to move forward with a different treatment option, in order to make sure that the offspring won't have that same genetic disorder. Most of the times, patients and their partners do not have the same genetic disorders, or they're not carriers for the same genetic disorders, because almost everyone is a carrier for some kind of disorder. But it's never really an issue unless the partner also has that same genetic disorder. Additionally, we'll do some consent signing. So this is just standard paperwork prior to an insemination, where we're just having the patient and their partner sign agreeing that we're using the partner's sperm for the insemination, or donor sperm, for example, for the insemination, and a COVID-19 form saying that both and the partner don't have COVID. Other consents might be signed as well if the patient, for example, needs an updated fertility panel or needed some vaccine that they didn't get, and it's just going to be like a waiver, for example, saying we're okay moving forward with the IUI. Like I mentioned before, too, sometimes the doctor will recommend a semen analysis prior to treatment in order to see if there's any male factor issues. We'll also send over some modules and order medications prior to starting an ovulation induction cycle, so that the patient and partner can get visuals and watch videos on how these medications work, how the cycling works. And sometimes prior to starting a cycle, we'll order an HSG or a saline sonogram, and both are testings that show, well, the HSG shows the x-ray of the pelvic organs, where we inject dye through the cervix into the uterus, and we get a visual of the fallopian tubes to see if there's spillage. So it often shows us if there is any blockage of the fallopian tube. So it would show us if the egg isn't able to travel to the correct place. And the saline sono is an ultrasound test where saline's injected into the uterus, and it can show any abnormalities. It gives us a picture of the uterus so that we can see if there's any polyps, fibroids, or anything there. And lastly, we would just have patients speak with billing to make sure they're all okay to start with an OI cycle. This is just standard like locations and monitoring hours. We have 5 different locations with different hours for the blood work and ultrasound that patients do every day. Our Bay Parkway office is just open 365 days a year. Our other offices are open only Monday through Friday, but all of this information is on our website as well. So beginning the ovulation induction journey, all a patient needs to do after they do their prerequisites, they have a protocol in place, so we know how they're proceeding, is to call on day 1 of their cycle, and we'll have them come in on day 2 or 3 of their period for baseline lab work and an ultrasound. So baseline blood work will show these 5 hormonal levels: estrogen, beta HCG level, serum progesterone, luteinizing hormone, and FSH levels. we're looking to make sure that they're all at baseline, hormonal baseline, indicating there's no activity going on. For example, no follicle already there that's producing estrogen or has a high estrogen level. And we're also doing ultrasound to check the uterine lining and ovaries to make sure, again, that there's no active follicles there, for example. So it's just to make sure everything is stable and no activity there so that we can start to give medication if that's indicated by the doctor. And every time a patient will come in for blood work and ultrasound, the nurses will give them a call the same day to let them know their next steps. So these are the medications we usually use for ovulation induction cycles. Clomid and letrozole are oral tablets that patients take, and Menopur, Organal F, or Follistim are injectable medications. Clomid and letrozole, the oral medications, are typically started on day 5 of a patient's cycle and taken for 5 days. Sometimes doctors will recommend starting them on day 3 of a cycle to prevent premature ovulation for patients who have shorter cycles. We recommend that patients take their medication in the evening or night around the same time every day. And every time they finish the medication, so if they're starting on day 5 and they're taking it for 5 days, they'll come back in on day 10 for blood work and ultrasound the morning after they finish the medication. Menopur, Gonal F, and Follistim are injectable medications. They generally stimulate the ovaries a bit more. They're a little more intensive than just the oral medications. And we start them on day 3 of the cycle and monitor the patients a bit more closely. These medications are also taken around the same time every day. They're given subcutaneously. It's a very tiny needle, so it's nothing too crazy. And we're typically advising them to do it in like fattier areas so they can do it in like their stomach or their thigh. And again, the same thing, after they finish the medication, they'll come back in the morning the next day. And the goal of all these medications is to stimulate the ovaries to help grow more follicles so that there's a higher chance of pregnancy through stimulation. Okay, so what we're looking for when patients come back in after taking medication is we're looking for follicular growth again. We're looking for the follicles, so the sonographers are going to measure how many follicles they have and the size of them. And we're looking for at least one mature dominant follicle measuring around 18 to 20 millimeters. Oftentimes when patients do finish the medication, they come in and the follicles might still be small. And if that's the case, we have them come back in 2 or 3 days, depending on the doctor's instructions and next steps. So it's not all the time that the medication works overnight. Sometimes they'll have to give them an extra dosage of the medication to stimulate the ovaries more if we don't see much activity there. But essentially, we'll bring them in a few times until we do see that mature dominant follicle there. And we're doing blood work and ultrasound each time that they come in. And every patient's body's different, so everyone responds on the medications differently. So some patients can respond quicker than others, and it's totally normal. That's why we just bring them in every couple of days to monitor them. And once we do see that mature follicle, we'll have them, once we see the mature follicle, we'll have them trigger with this injection called Ovidrel to plan for the IUI. There is a chance that their body can ovulate on their own. And when we see that with the blood work, we can have them come in the next day for the IUI, and they won't necessarily need the Ovidrel injection if their body is already ovulating for them. The Ovidrel is also subcutaneous injection. It comes as a pre-filled syringe, but essentially it's used to cause your body to ovulate, which is releasing the mature egg from the follicle. And we use it so that we can time out the IUI insemination with perfect timing. It's a one-time injection. We have patients store it in the fridge until it's ready for use. And we have them inject about 36 hours prior to the IUI. So for example, if I told a patient to trigger tonight, I would tell them to trigger sometime between 7 to 9 p.m., and I would have them come back in Friday morning for the insemination. So this is a picture here showing how IUI exactly is done. Essentially, what we're doing is once the lab washes and cleans the sperm sample, we're drawing it up in a catheter and directly injecting it through the cervix into the uterus. So it's getting it one step closer to where it needs to be so that the egg can be fertilized. Um, it can be used in a lot of different situations. So when there's, for example, like low sperm count or motility, when the lab washes and cleans the sample, we're only putting back the best, most motile sperm into the patient. And we also just use it for patients with ovulation issues, issues with cervical mucus, for example. Sometimes we'll use it also for patients with unexplained infertility. Yeah. So this procedure can also be performed with either the partner sperm, or if a person doesn't have a partner, with sperm from a donor. Typically, how we do an IUI is we'll have a partner come in about 2 hours before the actual IUI time to provide the sample, and it takes 1 to 2 hours for the lab to wash and clean the sample. Um, there is an option where if a partner can't come in for the IUI, we can have them freeze the sample in advance so that it's there the day that the patient needs it for the IUI. Um, so the washing procedure generally does take about 1 to 2 hours, while the insemination procedure itself only takes 5 to 10 minutes. At Genesis, the IUIs are conducted by the nurses, and oftentimes they don't really have discomfort. They just might have some mild cramping when we inject the sperm, and there's a possibility of spotting after the procedure, but we usually don't have that often. Again, this is another visual with how an IUI works. So it typically, it feels like a pap smear for most patients. So we use a speculum to find the cervix. Once we find it, we wash around the cervix with a median that makes it more of a healthy environment for the sperm to survive in. And then we directly inject the sperm through the cervix into the uterus there. Okay, after the IUI procedure, the typical instructions we give a patient is to take their prenatal vitamins. We don't we say to avoid heavy lifting, any abdominal workouts like running, jumping, anything that's strenuous. If their work isn't strenuous, they're allowed to go back to work, they're allowed to walk, they can do their normal activity. We do encourage intercourse the same night just to cover all windows and like cover the fertile window essentially. So no bed rest is needed, and they're allowed to pretty much go about their day. We just have them lay down about 10 minutes, I'd say, after the procedure. And then once they're ready to head out, they can head out. So after the IUI, 2 weeks later, they can do a pregnancy test. If they don't want to come back into the office, we do give them the option to do a home test and call us with the results, but they can come in for the blood work for the pregnancy test 2 weeks after. If positive, we do repeat that blood work for the pregnancy 2 more times just to make sure the levels are rising appropriately, which indicate that it's a good pregnancy. And if all 3 blood works look good, we'll have them schedule a 6-week scan with either our nurse practitioner or with one of the doctors. So some complications or outcomes that can also happen with IUI. There's a chance if a patient isn't responding on the medication that we'd have to cancel their cycle. If this happens, we'll have them revisit with the doctor to come up with a new plan of what to do next, essentially. If they want to maybe switch the medication, or if, for example, they might not be responding on any medication, they might move to IVF, for example. There is a chance of them over responding where their body can produce so many follicles that it would be unsafe to do an insemination if there's like a risk of multiples, which means like anything more than like 3 follicles, that could be a potential for pregnancies with more than 2 or 3 kids, essentially, which would be generally unsafe, and the doctors will often cancel the cycle if that's the case, if there's too many follicles there. And then if there is 3 to 6 cycles of IUI and they are unsuccessful, we will have a patient revisit with the doctor to come up with a plan for next steps as well. But usually we do recommend doing 3 to 6 cycles and then revisiting if necessary. The goals of the staff at Genesis is to make the journey as seamless as possible. It's not easy to have fertility issues at all. We want to be there to answer any questions and concerns that patients have, educate and teach them about their own cycles. Oftentimes we don't know 100% what's going on with our bodies, and the doctors can help us figure out exactly what's going on and just closely monitor us to see how we respond to treatment. And we definitely want to provide support and guidance to all our patients throughout treatment and just be there for them because it is a very difficult time. And here's an image of all of our doctors here. We have Dr. Chouari, Dr. Kotler, Dr. Grazi, Dr. Amin, Dr. Goyal, and Dr. Ross here. And here's our main phone number for our Genesis main number, our OI department, and our answering service that's used for emergencies and over the weekend. But thank you all for attending. I can answer any questions that you guys have. And if you guys want to email us at all, there's our email here at the bottom for the OI nurses. And we can answer any questions there too. Okay, that's a good question. If the baseline tests aren't normal, depending on how high the estrogen level is, and if we do see a cyst there that's producing estrogen, the doctor might make the decision to have the patient come back in for testing in, it could be a week, it could be a few days, and they're looking to see if the estrogen level goes down and seeing if that cyst there resolves on its own. If we have them come back in and we do see that it's producing more estrogen and not resolving on its own, we'll have them sit that period out, that month off, and then we'll start with the next period because they often resolve on their own. So a patient who has a shorter cycle, if the doctor indicates they need medication, they'll start them usually on day 3 instead of day 5 to prevent premature ovulation. So we're starting earlier to avoid hitting that day 10 where you might ovulate by starting the medication earlier than day 5. Yes, it is possible. And oftentimes that is what we want, to stimulate the ovaries and have more follicles, which give us more of a chance for one of them to be fertilized. The only time that it's really an issue is if there's too many mature follicles by nearing the ovulation time of a cycle. And in that case, it also depends on age, diagnosis, everything like that. So it's on a case-to-case basis. But for patients that are older, typically we do want this so that they have a higher chance of getting pregnant with more follicles. If a patient is younger and then there's too many follicles, that's when it becomes a little tricky. And depending on what the doctor thinks is best, it could cause a cycle cancellation. But overall, generally, we do want to see more than one mature follicle there, just not too many. So taking the oral medications aren't too bad in terms of catching up, for example. I mean, we won't say to double up or anything. We'll just say take it when you remember, or take it the next day if it's already the next day. In terms of if you forget to trigger, we would want you to call us, like call the service line if it's after hours to let us know. But we would have you come in the next day likely for blood work and ultrasound to see if the timing's still okay, and maybe the patient would still be able to trigger that next day. But there are options. It wouldn't be the end of a cycle necessarily. It's not big at all. I'm trying to think of what I could compare it to the most. I would say it's like this is gonna be a bad comparison, but like the very tiny like coffee stirs, like it's that like thinness of like the ones that are like straws, not like a wooden one, but yeah, like it's like the thinness of that. So very tiny. Having some discharge or spotting after the IUI is normal. It could be cervical mucus because it's ovulation time. Spotting is normal also though if it's like brownish, pinkish, even a little red, just because we are irritating the walls when we're going through with the catheter. So it is normal. So we do recommend waiting the full 14 days because we don't want to risk false positives. For example, when patients do take the Ovidrel injection, that is HCG, which is the pregnancy hormone. So if they test too early, a test might say they're positive, but it's just the injection in their body. And it's not like a true pregnancy. So we do recommend waiting the full 14 days before testing. So generally, no. I would say patients tolerate it very well. Patients who don't have a fair to medium to high pain tolerance, like if they know they have a low pain tolerance, we'll advise them to take Tylenol beforehand. For the most part, it does feel like a pap smear, so just some discomfort. When we're inserting the speculum, when we're finding the cervix, they just feel pressure for the most part. The time they might feel the most discomfort or pain, I would say, is when we are injecting the sperm, because the uterus is cramping because there's a foreign object entering it, and that can cause some cramping. They might have some cramping for the rest of the day, but we also tell them they can take Tylenol after the procedure. But for the most part, if they have no cramping at the time of the procedure, they won't have any for the rest of the day or afterward. But I would say it's generally not painful, just some discomfort for most patients. Not necessarily. If your doctor thinks you're okay to start with a natural cycle, they'll recommend that. A natural cycle would mean no medication, just maybe coming in for monitoring or testing for ovulation on your own. There are like at-home kits where we can test for ovulation, but there are situations if the doctor doesn't think medication is necessary, we can do a natural cycle. If a patient does really truly want to start a natural cycle, they can do that as well. Um, but yeah, we do natural cycles with just monitoring or at home monitoring if they don't want to start with coming in for blood work and ultrasound. So there are instances where we can do natural cycles. Some of them do. So Clomid, typically we don't have patients complain, honestly. Very rarely, I would say, there's complaints on the side effects of the medications. Clomid, what we get the most is patients will get headaches, and for that, we tell them mostly to stay hydrated, and it'll usually resolve once they're done taking the Clomid. But again, we don't really get that often. With letrozole, a side effect that we get is breakthrough bleeding, so they can have some spotting while taking the letrozole, but it does resolve usually when they're done taking the medication. And bloating can also be a side effect of just all of the medications, whether they're the injectables or the oral medications. Since we are stimulating the ovaries and growing more follicles, there is more like bloating there because your ovaries are being stimulated so much and there are more follicles. So for that, we tell them to just take Gas-X for the most part. So with IUI, we don't have the ability to do gender selection. The lab is just washing and cleaning the sperm so that we're putting back the best, most motile sperm. But unfortunately, with IUI, there's no gender selection there. We do see patients get pregnant with their first IUIs. Um, I would say if a patient doesn't get pregnant on their first IUI, they shouldn't be discouraged, because up to about 3 IUI cycles, each consecutive cycles, the chances of pregnancy get higher for up to 3 cycles. So the chance that it happens on the first try is not as high as it might be if they've had 2 previous cycles. So I wouldn't be discouraged if they don't, but we do see it sometimes that patients get pregnant on their first cycle.